Good afternoon, guys. I've got A for you. We'll discuss treating osteoporosis and preventing fractures. Okay. So here we go. The reference text is a caption for a health related video featured on a general interest media site. Based on the surrounding page content, it appears to be a short educational clip in which Dr. Daniel Naiju, a family physician with credentials in physical therapy and family medicine, emphasizes why it's crucial to treat osteoporosis and prevent fractures, particularly in aging populations. While the text itself is brief, the title and presentation suggest the video likely outlines the health risks associated with untreated osteoporosis and advocates for early diagnosis, lifestyle interventions, and possibly pharmacological strategies to reduce fracture risks. Given your interest in evidence-based interventions and age-related conditions, this clip might align with your broader focus on preventative care and cognitive health prevention. Want help summarizing what similar clinical guidelines recommended or exploring the implications of fracture risks on long-term care models. The landscape of osteoporosis treatment has expanded significantly in recent years, with several promising innovations alongside established therapies. Here is a snapshot of the latest developments as of 2025. Emerging advanced therapies. Abaloperidol recently approved in the UK. This anabolic agent stimulates bone formation and is particularly effective in reducing spinal fractures. It offers an alternative teriparatide with a slightly different receptor, affinitively, potentially improving outcomes for certain patients. Okay. All right. 3. Flow bone injections. A novel injectable hydrogel designed to enhance bone mineral density, and stimulate natural bone regeneration. It's it's minimally invasive and shows promise in preclinical studies for improving fractures uh, resistance. Okay, 4 osteogenetic oil oilogen jode oilojode uh, dio de, deoxynucleotides osteodns. These gene-based therapies, such as ISN40, target osteoblasts to promote bone formation at the molecular level. While still experimental, they represent a potential leap forward in personalized osteoporosis care. Okay, 5 agarine protein modulation. Research from Brazil has identified the protein agarine as essential for maintaining bone tissue uh, homeostasis, modulating agent agarine expression in osteocytes could open new therapeutic avenues, especially for age-related bone loss, uh, adjunctive strategies in special populations. Cancer-related bone loss. Patients undergoing immunotherapy or hormone-based cancer treatments face increased fracture risks. Anti-restorative agents like bisphosphonates and demoxestrobin remain underutilized in this group, despite the proven efficacy in mitigating treatment reduced bone loss. These innovations not only aim to reduce fracture risk, but also support independence and cognitive health in aging populations. A key concern in long-term care planning, given your interest in systematic reform and precision medicine. This integration of gene-based therapies and diagnostic equity, e.g., universal fracture liaison service, could be practically impactful. Would you like a comparison matrix of these treatments by mechanism, effectiveness, and accessibility, or perhaps a deeper dive into how these therapies intersect with uh, dementia risk and care transitions? Great question. Let's break it down by comparing traditional therapies like biophosphonates and hormone-based treatments with the latest innovations in osteoporosis care. Traditional therapies, biophosphonates, uh, allogenate, allogenate, rhizodronate, um, zoledronic acid mechanism inhibit bone reabsorption by oste, osteo, osteoclasts. B. Strengthens proven to reduce spine and hip fractures, widely available. Limitations: GI side effects, long half-life, rare risk, leg jaw, osteocrocytes, and atypical femur fractures. Dim denosumab, Prolia, mechanism, monoclonal, monoclonal, monoclonal antibody that inhibits osteoclast formation, strengthens effective for patients intolerant to bisphonates. Limitations: requires ongoing use, abrupt discontinuation, can lead to rebound fractures. Hormone therapies, estrogen, okay, mechanism mimic estrogen's protective effect on bone, uh, strengthens unuseful in uh, postmenopausal women, limitations, increased risk of thrombolism and certain cancers. Newer and emerging therapies, ab, ab, abaloperitide and terlip, terlip, aside mechanism, and anabolic agents that stimulate bone formation. Strengths build bone rather than just prevent loss, reduce vertebral fractures. C. Limitations, daily injections. Limited duration of use, typically 2 years. Event, eventi mechanism, dual action, stimulates bone formation and inhibitors absorption. Strengths, rapid release in bone density, limitation, cardiovascular risk in some patients, monthly injections, gene-based and regenerative therapies, osteodns, and flow bone hydrogel. Give me 1 second, guys. Mechanism targets osteoblasts or enhances bone matrix regeneration. B. Strengths potential for personalized personalized long-lasting effects. C. Limitations, still experimental, not yet widely available. Key differences. Feature, traditional therapies, newer therapies. Inhibit bone loss, stimulate bone formation, some dual action. Delivery, oral, IV, or subcutaneous. subcutaneous. Okay. Mostly injectable daily or monthly. Onset of effect gradual, often faster. Romo Soza Roma Soza or Sozumab. Romo Sozi or Sozumab. Personalization. One size fits most. Moving toward biomarker guided approaches. Risks. GI issues, rare fractures, cardiovascular, long term unknowns. If you're thinking about how these options fit into your broader care models, especially for aging populations or those with comorbidities like cognitive decline, I'd be happy to explore how treatment choices might influence independence, fall risks, or even transitions in care. Want to go there next? Newer osteoporosis treatments, especially these that stimulate bone formation, offer exciting benefits, but they also come with distinct side effects profiles worth weighing carefully. Here's a breakdown of the most notable ones. Anabolic antigens. Okay. Abaloperitide. Teriparatide. Common side effects: dizziness, nausea, leg cramps, and injection site reactions. Serious risks. Rare cases rare cases of osteosarcoma, bone cancer, in animal studies, though not confirmed in humans. Clinical notes, typically limited to 2 years of use due to long-term safety concerns. Eventi, common side effects: joint pain, headache, and injection site reactions. Serious risk, increased risk of cardiovascular events, heart attack, stroke, especially in patients with prior heart disease. Clinical notes: Dual action builds bone and shows reabsorption, but cardiovascular screening is essential before prescribing. Experimental therapies: flow bone hydrogel, osteodns. Current status: still in early phase trials or preclinical stages. Potential concerns: long-term immune response, off-target effects, and unknown durability. Clinical note: promising for personalized care, but not yet approved for general use. Broader considerations for aging adults, especially those with cognitive decline or multiple comorbidities. Side effects like dizziness or cardiovascular strain can increase fall risks or complicate care transitions. That's why treatment selection often balances fracture prevention with functional independence. Would you like a decision matrix that compares these therapies by risk profile, duration, and suitability for different patient types? It could be a helpful tool for care planning and policy evaluation. Absolutely. Let's unpack the risks of newer osteoporosis treatments with a bit more nosh, especially since many of them are still evolving in clinical use or under investigation. Eventually, cardiovascular risks. Most significant, certain is an increased risk of heart attack, stroke, and cardiovascular death, particularly in patients with a history of heart disease. This has led to a box warning and careful patient selection. Other effects: joint pain, headache, and injection site reactions are relatively common but manageable. Anabolic agents, osteosarcoma, theoretical risks. Animal studies showed a link to bone cancer, though this hasn't been confirmed in humans. Still, it limits use to no more than 2 years. Other side effects: dizziness, nausea, leg cramps can affect adherence, especially in older adults at risk for falls. Essential therapies: flow bone, hydrogel, osteo DNS, immunogenicity, because these are biologically active or gene based. There's a potential for immune reactions, untreated effects on non bone tissues, durability, and reversibility. Long-term effects are unknown, and if advised effects occur, they may not be easily reversible. Demosamab, Prolia, often grouped with newer agents, rebound fractures. If stopped abruptly, it can cause a rapid loss of bone density and multiple vertebral fractures. Infection risks. As an immune modulating monoclonal antibody, it may slightly increase the risk of infections. Broader implications for older adults, especially those with cognitive impairments or frailty. Side effects like dizziness or cardiovascular strain can increase fall risks or complicate transitions in care. That's why risks, satisfaction, and community of care are also crucial when choosing these therapies. Would you like a virtual summary or decision matrix to help compare these risks across patient profiles or care settings? It could be a great tool for evaluating policy or clinical pathways when comparing the overall safety of osteoporosis treatments. The key differences in their mechanism of action, duration of use, and patient specific risks. Here's a structured overview to help clarify. traditional therapies, bisphonates, and alendronate, zolendronic acid. Safety profile. Generally well tolerated with long-term use data. Risk. Rare but serious side effects. Atypical femoral fractures and osteoporosis of the jaw, especially with prolonged use. Okay. Rare but serious side effects like atypical femoral fractures and osteonecrosis of the jaw, especially with prolonged use. Best for first-line use in many patients, especially those without issues or renal impairment. Safety profile. Effective and well tolerated but requires continuous use. Risks. Rebound vertebrae fractures if discontinued abruptly. Slight increase in infection risk. Best for patients who can't tolerate bisphonates or have kidney issues. Newer emerging therapies okay, that's done. Best for high risk fractures, patients without cardiovascular history, anabolic agents. Safety profile. Stimulate bone formation, limited to 2 years use. Risk. Thoracical risk of osteosarcoma from animal studies, dizziness and nausea for severe osteoporosis or multiple fractures. Experimental therapies, flowbone, osteoDNS. Safety profile, still under investigation. Unknown long-term effects, potential immune responses. For best for fracture, personalized medicine pending further trials. fall risks. Dizziness or muscle cramps from anabolic agents can increase fall risks in older adults. Okay, guys, so that is A for you. I'll be back on shortly with B. Till then, Gator Wellness. Take care.